bit or reform a lot the single family housing zoning that covers much of the United States. And a third post will be coming soon, Monday or Tuesday, on right to counsel, tenants' rights to counsel in eviction cases. So we're covering sort of the waterfront of housing and community policy. I hope you enjoy it.
Thanks, Bruce. Next, I'm going to drop in the chat our next month's event. The June Housing Hangout will be on reproductive justice and its relationship to housing issues. Erica, are you on the line today? I see your name there. Are you able to say a few words about next month's Hangout?
I have some background noise. Can you hear me okay?
Yes, we can.
Yes, so we have our housing hangout will be on the housing crisis and how it impacts reproductive justice. So we'll be first defining what reproductive justice is and what are the connections to housing and housing security and insecurity. And we'll be collaborating with Voices for Reproductive Justice, which is a collaborative community partnership with faculty and community partners at the Department of Public Health Education at UNCG.
Thank you so much.
Looking forward to it.
We're looking forward to that one. And again, the Eventbrite is in the chat. You can go ahead and get your reserved spot. We will be changing the link to go.uncg.edu/housing hangout just after this event. So it will point to that Eventbrite page. We'll also have it on all of our social media in case that's how you access our resources. Finally, I'm going to drop in the chat the Eventbrite for our Community Workday. This is a series of community cleanup activities in the Bingham Park and Apache Park areas of the Cottage Grove neighborhood. It's supported primarily by a Water Resources Research Institute grant for stormwater cleanup. We've been going along the creek bed and removing trash and debris. Sarah's smiling there. It helps make that hydrology and ecology better for plants and invertebrates and all kinds of microorganisms that we want to thrive in that area. We also spend time talking about the environmental and racial justice issues of the landfill under Bingham Park. Next month, we're anticipating having a hot dog luncheon following the event and some opportunity to talk about environmental justice in general. So again, that's in June, and the link is in the Eventbrite and in the chat. We'll post those again on our website and in our newsletters and on our social media, so you can join that way. Well, I'm going to turn things over to Destiny now to introduce the speakers. Again, Destiny Alston is a very recent graduate of the MPA program at UNCG and a former graduate from the bachelor's program of sociology at UNCG. I had her as an intern a couple of years ago in the internship class, and for the last 6 or 7 months, she's been working with the Center for Housing and Community Studies as a research assistant on our mediation project. Destiny, it's all yours.
Thank you, Dr. Sills. So our four panelist is Nakia Brown, and she's currently completing her Master's of Clinical Social Work and is a case manager for the Interactive Resource Center in Greensboro for PATH, where their goal is to reach individuals experiencing homelessness in Gifford County who may suffer from various symptoms of severe and persistent mental health. Then our second panelist, which is Brooks Ann McKinney. She's a social worker and has 20 years of experience working with the homeless population in healthcare. She's the head of vulnerable populations at Cone Health System in Greensboro, where she successfully implemented CLC models and increased collaboration between the hospital, community partners, providers, and public housing entities with the goal of ending homelessness. Our third panelist is Lindy Garnett. She served as the CEO of the YWCA Greensboro for 11 years. She currently serves as an adjunct associate professor for the University of Maryland, Global College in the areas of diversity, awareness, and disability studies. Lenny's passion has centered around advocacy programming for disenfranchised populations, including persons with mental illness or cognitive impairments. Finally, our last panelist, Valerie Jones, is a licensed therapist and a systems of care coordinator at Sand Hill Center. She's very passionate about her involvement with children's mental health and considers this a lifelong calling to help those in need. So I will begin. So our first panelist will begin with speaking, and we'll do this in a round robin format. And if you have any questions, please feel free to pop them in the chat box. Thank you. Nakia, we're ready when you are.
All right. Thank you, Destiny and UNCG, for having me to be a part of this housing hangout. This is my first time and I'm excited. This panel of community liaisons is an important part of the collaboration to create innovations that are necessary for mental stability of our homeless population here in Greensboro, to maintain housing once permanent housing is secured. So again, thank you. As Destiny mentioned, I'm Nakia Brown. You can call me Nakia. I am a PATH case manager. PATH stands for Project for Assistance in Transition from Homelessness. And I'm a part of a remarkable team of folks who truly have a heart for this work. Here we provide case management outreach where we meet people literally where they are, in tent encampments in the woods, under bridges and abandoned buildings, or just on the street flying a sign. We seek to screen people for serious mental illness. We look for PTSD, major depression, bipolar disorder, schizoaffective schizophrenia, and who are also chronically homeless. So 12 consecutive months of homelessness, or a total of 12 months over the past 3 years to meet qualifications for our program. We provide community service referrals, complete treatment plans, as needed crisis interventions, intakes to establish a person-centered plan of goals, and anything that the client just wishes to do or accomplish within their time in our program. Our outcomes highlight primary medical care, health insurance, community mental health, temporary housing, permanent supportive housing, substance use treatment, income assistance, and employment assistance, all of which are important in securing and maintaining permanent housing. I'm sorry, y'all. I'm not used to sitting down and talking, so I'm like trying not to move around and like wiggling in my chair. But overall, these services that we provide, among many, as we know, are essential and impact housing. For the housing programs that we utilize, disability is a requirement, and they must meet chronicity, meaning literally homeless, because disability impacts housing. So when it comes time for housing, our team works to get them housing ready, which means we basically start with basic needs first: food, clothing, supplies, temporary shelter, water, assisting with getting vital records, things that they will need once they're in the housing process. We discuss mental, physical, substance use treatment, and what those benefits look like and how it will help them once they are housed. This is usually their primary long-term goal. And we also help them process the importance of these services and short-term goals that lead to a stronger foundation for housing. Things like medication management, community support, intensive case management. That's when they can work with an agency who can see them more frequently due to the severity of their mental health. Peer support groups where they can talk with people who can relate to some of their fears and mistrust, frustrations, and other residential support services once they're housed. So we network with a lot of community partners to build and grow a strong community support system for our folks, so that they truly thrive in and out of housing and try to maintain stable housing. So all of that sounds really good. It's all fantastic. It's a great plan to end homelessness in Guilford County. But honestly, there are a few barriers that arise and challenges that we all face. And, unfortunately, we just have to do our best to overcome some of those challenges and work together to see what we can do to support this most vulnerable population of people. But we also are aware that we can't force people to do anything they don't want to do. So by not receiving services, that's their right, that's their choice. However, by not receiving those services, this does affect their ability to remain housed. This can be physical, mental, or substance use. Some services are kind of hard to secure, like disability, especially for people who have mental disability and not necessarily physical disability. Our clients must be active in making sure that they have supportive services to show a history of their mental health, and that it's something that is of long-term issues for them. This makes it difficult to obtain housing. They are denied income, have no employment, and it can result in them losing their housing. And it just begins like a repetitive cycle. Same thing with substance use. So just a lack of consistency is pretty common. So then the question is, well, how does this impact housing? By doing things in the community or within the neighborhood, can cause them to terminate their housing because they have behavior issues. They're not abiding by their lease. Landlords don't want to work with them. Unfortunately, the type of company that they keep, who they allow to come into their home, can cause them to lose housing. If they don't have the skills really that they need to maintain housing, like understanding the importance of cleanliness, that can result in termination as well. Landlords and property managers evict them or terminate their lease, and ultimately don't want to work with our population because they, are used to this type of behavior. And unfortunately, it makes it harder for people coming behind them and harder for providers to advocate for their clients because of the history that others have preceded previously. Not receiving treatment services for addiction or mental health leads to a downward spiral. And sometimes our clients realize later that, oh man, I'm losing my place, and they want to do what's necessary to maintain it and keep it. But unfortunately, sometimes it's just too late, when there's nothing they can do because the damage has already been done. Just understanding the need for collaboration in services to try and encourage our folks to see the importance of, taking advantage of what's out here. I mean, these are things that can help you. They benefit you. Providers get a chance to help them get back on track, stabilize their housing, and maintain their housing through residential supportive services. So that's kind of where we are. I can pass along, I can get a little long-winded, but thank you so much.
Thank you, Nakia. Let me see. Brooks Ann, are you ready?
Yes.
Okay, great. Thank you.
Thanks, Destiny, and thanks, Nakia, and thank you for UNCG for discussing this, especially because it is Mental Health Awareness Month. So everyone, if you want to go to NAMI.org, it's a great organization if you want to look at other ways to volunteer or support mental health services in the community. First, I'd just like to say that no one can be mentally or medically stable without housing. So you have to have a roof over your head to be able to get enough sleep, eat properly, take medications, and number one, to feel safe. So first, I'll just say that we need affordable housing, number one, because if people do not have a place to go, then they can't stabilize mentally. So I think that's just important to discuss. But also, second, we need more mental health services to be available to the most vulnerable and uninsured. And over the years, I think I've just seen hundreds of patients that struggle with schizophrenia, depression, and other debilitating illnesses. But too many times we see individuals that finally get into housing. And once they do, they may lose their voucher due to not having enough stabilizing mentally. So if they don't have the support services, like Nakia said, with the PATH team or community support team, ACT, or have family or church. And then also when it comes down to serious mental illness, you need the medications and therapy and psychiatry. So I think it's really hard, especially on the hospital system side, when we see people that readmit over and over because they don't have that that support. And I remember back in Raleigh, for an example, we had a client at the rescue mission, and I was the director of medical respite, which means beds for people that are discharged from the hospital, that are too sick to be on the street, but they're not sick enough to be in a hospital bed. And we had beds at the rescue mission, and we had a client, I'll just call her Jane, and she lived on the streets for 25 plus years. And she would only come into the emergency shelter when it rained or when it was cold. But when she would come in, she would always had 2 bats, and she would have to give me her bats. And she wore these big chains because she said these chains protected her under her clothes. And we loved her. I mean, she's the sweetest lady. And we finally got her into housing, and it took 3 different locations until she felt safe, but also just mentally stable enough. So we finally got her to start taking medications, and she got into a program that really supported her where she was. And so it just shows that how much, even if we do have the housing, if they do not have support, that it's really hard to stay stable. And I think it's important to look at this historically, because you can look back at when in Raleigh, when Dorothea Dix closed, I think it was 2008, 2009, and I lived there. We saw a sudden increase of patients released into the community that had been institutionalized for years. And it's just like going back to the Reagan years. And all of a sudden they were expected to be in a community health model when they had known nothing but hospital walls for years. And so many people became homeless, and we had to come together and we formed a mental health respite program. And this is just, I'm just saying this as an idea of a solution. When they were discharged, they had a bed at the shelter for 30 days, and we made sure they got their medications, therapy, and worked with getting housing vouchers. And at the same time, tried to get community support teams, ACT teams. And we just saw a great success with that program, just due to that transition from a hospital to a home is not very quick, like Nakia said, especially there's not vouchers, but also with support. And I think with my advocacy hat on, we obviously need Medicaid expansion so that everyone be able to receive insurance. A lot of the programs that we're talking about, even Nakia was saying that, now with PATH, if people, don't have, if they have Medicaid, they can't get PATH. And then you have people that can't get Medicaid. And if we had expansion, then that would increase services for the homeless and uninsured. However, we're doing the Medicaid transformation path, and that still is going to cause a big gap in services for people that do not receive Medicaid. And there's only a limited amount of IPRS funding in the state, which is the funding that LMEs receive, like Sandhills. So Valerie might be talking about that later, to give services to the people that have severe and persistent mental illness. Because as July 1st comes around, there will only be certain agencies that will receive the Medicaid contracts that will have the mild and moderate symptoms, but the people that have severe persistent mental illness will go under the tailored plans under the LME, which is Sandhills in our region. So I think we really need to advocate that there's increased IPRS funding in the state, especially for the most vulnerable, because if we do not have the services to be reimbursed, then we can't give them the mental stability and services that they deserve. So I think going forward, I keep saying I think over and over, we really are going to have to advocate on a patient by patient basis, because when someone does have a mental health crisis, there's certain things that have to, under a definition, for them to receive services. And if someone's not advocating for them, then it'll be very hard for them to receive it. So I think that's really important as we go through this transformation, that we really speak up for the ones that have severe mental illness, but also with the mild and moderate symptoms, we know that at any moment, those can get worse. And so we need to really support those, even with depression and people that especially have gone through trauma. I think that's a big issue now, especially with COVID and everyone's experiences with that. But we really just need to support each other, but also just think about ones that are uninsured. I will say that with FQHCs or community health centers, they do receive funding for uninsured, so they can treat behavioral health as well as primary care. And a lot of funding coming down from the Biden administration is going to community health centers. And as we do see more funding going into housing and opportunities, I think we just need to make sure that we look holistically at our housing plans too, that we include as many services as possible on site, because I think that really especially supports ones that are going into housing for the first time, and if they've been homeless for a number of years. So that's permanent supportive housing model. That's where I was leading to. But yeah, I'll just say from also the Cone Health has really been dealing with COVID, and they've been really awesome about making sure that with testing and vaccinations, that's been a lot of the focus. But going forward, I think more and more we'll see opportunities for partnerships. And if you look at other states that have had Medicaid expansion, there's been more funding from MCOs to help with housing and services. So I'm hoping that those examples will bleed into North Carolina, so that we can more and more work together as a system to help the most vulnerable. So that's all I think that I will say, unless people have questions afterward.
Thank you, Brooke. Actually, I do have one question for you. I know that you really emphasized just advocating for that client, but what are those steps for, supporting that client that does have mental health concerns?
Well, I think a lot of times it's it depends on depends on the LME that's in your region, which would be Sandhills. You do have the call-in center, and Valerie probably could get those details at the end. But to call and make sure on the hospital side, there's like a liaison or a coordinator. But if you call their hotline and help them advocate and say, this is what they need, and also the patient obviously would speak up for themselves as well. But I think what I've had to do in the past is sometimes help with that historical data or medical treatment, showing that they've been in the hospital for a number of times or have received treatment before. Because if they can prove that, that's a lot of times why they will receive the service. So I think proving that definition for reimbursement, it's probably the first way to advocate, but calling the Sandhills line and going to their website is definitely the first step before you get into all those details that I was talking about with receiving the service.
Okay, thank you.
I did put the number to the Sandhills Center call to the Sandhills call center in the chat box.
Great. And I think now we're seeing a lot more, obviously, telehealth services and due to COVID, but I'm hoping that as we go into the transformation, that more and more agencies will be coming to where people are, because I do think, especially with the homeless, it's hard to do either telehealth, but also just to build trust sometimes that way. So I'm hoping they'll have more outreach going forward.
I think, I'm sorry, I didn't mean to interrupt, but Brooksane, you made a really good point about like the importance of gathering those medical documentations and promoting advocacy, because it's really hard. And I do like the integrated care model, because mental health and the medical system can, collaborate and kind of feed into each other. Sometimes I think about some of our clients who are, who have severe and persistent mental health, who refuses to go to the doctor. And so it's difficult to get those records because they're unavailable, they're not there. And so then we try to go mental health route and then possibly, primary care. But for those who, for whatever reason, don't have that documentation, what would you suggest as an alternative?
Well, just from doing for disability claims for a number of years, and a lot of times it's working with a doctor that has relationships or will go out into the community, and we do have, we're very lucky to have a couple of those here in Greensboro, because a lot of times that documentation, you need a doctor's signature to get what you need. And so I think a lot of times as a case manager is to go to the doctor that they have seen, or find a doctor that can come see them where they are, and get that from the EMR. And I just know for anyone that does have a client or patient and needs help with that, I can also help on the Cone Health side. Obviously we'll have releases that need to be signed and things like that. And sometimes that can be difficult, especially with schizophrenia and stuff. But I think building that trust is important. And I'll just say, with COVID, the more that we did the testing, especially at the shelters, I could see how people trusted the medical community more. So I think that's just one example of how once you have that relationship, they may be willing to sign for that release. But like I said, anyone that needs help with helping getting documentation can email me if you have a specific person. I obviously get a release signed first, and then I can hopefully help, especially with like disability claims. It's pretty critical to have those records.
Well, thank you, Brooks. And Landy, are you ready?
Hi, yeah, I'm Lindy Garnett. It's always kind of hard to go in the third position because you guys have covered a lot of important information already. So I want to go in a little bit different direction, I guess, because I think sometimes I think that we have over romanticized both homelessness and mental illness. And in some ways, we've kind of shot ourselves in the foot because people are dedicated and passionate about doing this work. And I think sometimes we try to make it look easier than it really is. And I think the community sometimes feels a little let down when things don't work spectacularly well without really understanding some of the complexities that are involved in the work with folks, particularly folks with serious mental illness. So one of the things that that I think is sometimes a little tension provoking, and Nakia addressed it some, and Brooks Ann also, is the issue of kind of housing versus services. And the housing first model, when that kind of came into being, really spoke to the fact that, there are people with mental illness who live in houses, and obviously having a mental illness doesn't preclude your ability to live in a house. So obviously that problem would be solved by putting people in houses. And to some extent that's true. And as Brooks Ann said, it's really hard to stabilize when you don't have a place to be. But it's also often not enough just to put a roof over someone's head, because what we find is, as other people have alluded to, folks that, and often related to their illness, are not able to comply with certain things or to do what we think they ought to be doing, and that then jeopardizes their housing. So it's great to put them in a house, but if they can't stay there because of other factors, then we've got to go a step further beyond just putting people in a house. So, and I think that we have not, in my opinion, we have in some ways, over professionalized homeless services, and kind of built a system where people have to jump through lots of hoops and go through lots of formal processes to get help. And I'm kind of a big fan of making things sometimes simpler. And I'm also a big fan of, when we talk about disability in general, one of the models of disability that we talk about often is the social model, which really speaks to the fact that a lot of, quotes, disability is created because people don't fit a norm that we've created, and that we can solve a lot of problems by changing the norm. That all of a sudden you're not as disabled if we change what the requirements are for folks to function. So some of the things that that cause folks with mental health issues problems in the community and in housing, we could fix by just changing those rules. The other thing is that I think that we far underuse and underestimate the power of folks that are not professionals in dealing with this issue. We've had great success in various places with building an army of volunteers, an army of people who aren't paid. There's never going to be enough paid providers and enough money to keep throwing money at this issue. So I think, I'm a fan of getting very, very creative and looking at what are ways to do some things that maybe don't cost us a whole lot of money, and that we don't have to wait on something to happen to be able to do. And one of those is building informal support networks. Because again, most of us, and I think sometimes we like to think that that folks that are experiencing homelessness or folks that have mental illness are very different than us, and they're really not. But most of us have some kind of a system around us. Most of us are not. Now I tell people one of the great American lies is that we should all be independent, because I don't know many people that are truly 100% independent. Now, I don't fix my own car. I don't have my own cows. So, few of us truly are independent. We are very interdependent. And for a lot of us, that's family, it's friends, it's family that we build around us. And sometimes that is more challenging for people that are experiencing certain kind of issues. So I think working around increasing those informal supports, whether that's through, faith communities have been very important in some of that work, as well as others. But I think, when you one of the things that we looked at was kind of for lack of a better term, an aftercare program where people would get introduced to folks and help with building some of these informal supports. And then those folks would drop by their house to visit, not to inspect, not to, document their progress, but just to visit and see how they're doing. And in that process, would see things that might need to be done and could offer some assistance and advice without it necessarily having to be such a formalized service. So I really want to, I would like to see us get better at that. And I'd like to, the other thing that we've had some success with is community education, and particularly working in the housing market with people, because I think sometimes people are, we're afraid of things that we don't understand and we don't know. And, it's unfortunate because probably most people on this call know that folks experiencing mental illness are more likely to be victimized than they are to be a perpetrator of a serious crime. Yet the public image that we have is that anybody who's walking down the street talking to themselves is somehow a danger to me. It looks like if you read the paper that that's really not who's a danger to you or your kid at all. It's some very mainstream people that are much more dangerous to you. So I think, helping people understand more about what does this mean, so that they're not so frightened and then treat people in ways that are counterproductive. Because, the more rejection and the more negative interactions that folks have, the more it exacerbates some of the things that are causing a problem in the first place. So I think just better public education about, what are mental health issues? What does that mean? And what do we do about it? Why don't people take medication? Why don't people go to the doctor? Well, read the side effects on some of those medications and the answer becomes pretty clear. So I think to help people understand kind of better about how people get where they are in ways that we could help them. And also working with landlords, because again, people are, people want their property and they have a right to have their property be cared for and to not be destroyed. And but we've done well with particularly smaller landlords who aren't big conglomerations, although we've had some success with some bigger places too. But really saying to them, we're going to back this person. We're going to be responsible. So if there's damage, we'll pay for that damage. We will be responsible if there's a problem. And if somebody can't stay in their housing, then we'll get you another person to go into that housing so that you're not sitting with empty property and not getting your rent. So sometimes that backing can be very useful to help let landlords know that they will be made whole if there's a problem, but that we need their help. And again, helping them understand some of the things that they may see or they may hear, and not to automatically be freaked out because somebody's doing something that they don't quite understand. And I think, it's also important, I think, this issue of a chicken or an egg, that, homelessness can be caused by mental health issues, and mental health issues can be caused by homelessness. So, I think we need to be more on top of folks that are experiencing really tough times and kind of looking at protective factors to hopefully help those folks from going ending up in that situation. So it is, it can be both. And without a doubt, being homeless exacerbates a mental illness if you, don't, as Roxanne said, if you don't have a safe place to be, if you don't have a place to eat, if you don't have a place to sleep that's decent, that can be a problem. And then I guess lastly, I would say that while I'm on board with most folks that ending homelessness is a goal, I'm also, I think, maybe more pragmatic and realistic that that sometimes this is a cyclic kind of a thing, and that sometimes that's just, it is what it is. It isn't something that we are necessarily going to solve, but it's something that I think we need to be prepared to deal with in a better and more productive way. That we don't talk about somebody coming out of housing as a failure, but that is just part of a process. It's kind of like people getting clean and sober. We don't know what time is going to be the magic time. We don't know how many times somebody's going to get clean before they stay clean, or maybe they don't stay clean. Maybe, but each stretch of being clean is a success in its own. And during that period of time, growth can occur and other things can happen. So I think to not frame this so much in terms of who succeeded, who won, what program is the best because it works. I think different things work for different people. And depending on who you're working with, somebody losing housing may not be a failure. It may just be a step along that journey, and that we just continue moving forward rather than seeing that as, oh, well, see, it didn't work. I think sometimes we forget that people with mental illness and people who are experiencing homeless are as individual as everybody else in the world. And it's unreasonable to think that there is one system, one way, one best practice that's going to work for all of those people. And again, to kind of simplify things, I think sometimes we miss the obvious, like sitting and talking and really listening to people about what do you need, rather than this is what we offer, so this is what you get. But what do you need, and how do we construct what people need in order to be successful, and how do we get better at truly listening and believing that people are experts on themselves, that typically people know more about them than we do. So and sometimes I think, again, we kind of overcomplicate. Sometimes what people need is not all that sophisticated or a big deal. Sometimes it's fairly small things that we just miss. So I guess that's what I would, that's my 2 cents.
Well, thank you for your 2 cents, Lindy. You made some great points. Valerie?
I'm here. Can you see me?
Mm-hmm.
There we go. Hey, everybody. I'm Valerie Jones, and I'm a mental health counselor, and I have been for about 21 years now. I currently work at Sandhills as the system of care coordinator, but the vast majority of my career I've spent working with women and children. So they're kind of my niche, and I'm going to talk about them today. Next slide, please, Dr. Sills. So housing instability is defined not necessarily as, just one thing. There's a variety of challenges, such as moving frequently and having difficulty paying rent, being overcrowded, having to live with relatives or friends at random times, or when your rent or the cost of housing takes up the majority of your income. So, we've talked a little bit about just flat out homelessness, but there are layers of instability. And as a therapist working with women and children and families, but primarily these families have been headed up by women, I'm going to share with you a little bit of what I've seen, the different layers of instability, maybe not necessarily homelessness, but maybe some behaviors that eventually lead to homelessness. Next slide, please, Dr. Sills. Okay, so, basically, a lot of us have some background in mental health or, working with people, sociology, those kinds of things. But basically, human beings, we are wired to seek rewards, pleasures, and avoid loss or pain. So when someone has a mental health disorder, there's kind of like, the process is skewed, or it's a little bit dysfunctional as to the efforts and the methods that they use to try to achieve the things that they want and avoid the things that they don't want. I mean, these are normal functions of human beings, but when there's a mental health disorder, that process becomes, and the picture of what that looks like becomes a little dysfunctional. Next slide. So, we talked a little bit about the people that we work with and families and women seeking mental health treatment. And I can just tell you, there's lots and lots of services for children out there. And there's a lot of services for adults as well. But sometimes, access to those services, there can be barriers. So we will find times when people's mental health problems go untreated. And so when those mental health problems are not treated, they can lead to poor decision-making skills, poor social skills, risk-taking behaviors, impulsive behaviors that they either will not or cannot control, decreased levels of motivation, and poor physical health. And also, I think, Linda, you mentioned earlier about victimization, someone did, but certainly having a mental health problem makes you more likely to be victimized by someone else. Next slide. So I'm just going to talk a little bit about, kind of just give you a case scenario, the Berry family. Next slide. So Miss Berry is a 35-year-old biracial female. She was emotionally abused as a child. She lived in foster care homes, and she was emancipated in her late teens. She did not complete high school. She dropped out in the 9th grade. She has 2 school-age children, and she uses alcohol heavily. She's not really an alcoholic, but she drinks and parties a lot. She's suffering from narcissistic personality disorder. Next slide. So let's just take a look at some of the symptoms of this disorder. Someone who has narcissistic personality disorder can be overly boastful. They want to exaggerate their own achievements. They pretend like they're superior to others, and they lack empathy for other people. They tend to look down on other people as being inferior and see themselves as being superior. They monopolize conversations. They become impatient. They have anger problems. They're often unhappy, depressed, or have mood swings when they are criticized. That's a big trigger for them, is when someone criticizes them or tries to provide even constructive criticism. They're easily disappointed when the expected importance is not given. They always crave for the best in everything and have a very fragile self-esteem. So Miss Berry, obviously, you can stop and think about, okay, how are these mental health symptoms going to affect her life and her lifestyle? She's very self-absorbed. She seeks gratification from other people admiring her, and especially admiring her from the perspective that she wants them to see her in. And she has bouts of what we call narcissistic rage. And so this is a reaction to a perceived threat of self-worth. So whenever someone tries to point out that maybe, you know, she's not quite as important as she thinks she is, or she's not quite living the high standard that she wants everyone to believe she is, she can have severe fits of anger and rage. Next slide. So let me move my little thing here. All right. So Miss Berry doesn't like her past and feels she has overcome her childhood experiences. I think I got an extra word in there, sorry. Feels like she's overcome her childhood experiences. She has a need to be present as if she's doing as well. She has the need to present as if she's doing as well as anyone with higher education and a more stable childhood, in an attempt to hide her inadequacies. She earns minimum wage, but used her tax refund to rent a house that was beyond her financial means. She brags to her friends and coworkers about the size of her home and her, material possessions. Within 4 months, she could no longer afford the rent, and this resulted in her and the children being evicted. They moved into a hotel for about 6 weeks, one of those hotels where you kind of pay by the week. And they stayed there for about 6 weeks. During that time, she met another man, and she quickly got in a relationship with him. They moved in together. She was insistent that they had to find, another large house. I mean, no matter what he pointed out, an apartment, no, nothing was good enough. She had her eyes set on something very grand, but it wasn't in her budget. But, living in a big house would validate that once again, she was back on top. Well, so her and this gentleman moved in together. And, because she has problems with relationships, she couldn't get along with her new boyfriend. And because she's so grandiose and has this inflated sense of, self-esteem, she wasn't willing to compromise and work on the relationship. And so very soon he moved out. Once again, it took about 3 months and she could no longer afford this house that she was in. And so once again, she got evicted. And so then there was a similar pattern that just repeated itself for many years, this whole thing of, in and out of houses and always biting off more than she could chew, always looking for something bigger than, her wallet was. And so the children would move, and honestly, this was year after year after year, the children would move at least about 3 times each year, often living in hotels, having to change schools. They lived with a sense of insecurity, and they were picked on by their friends. Miss Berry is consumed by her own needs, and she has no concern for the impact of constantly moving around has on her children. She dismisses and minimizes the incidents when they are living in hotels and never considers that they are experiencing homelessness. So, as you can see, this is like, if you would want to say, like, how does a mental health disorder impact, someone's housing stability? Once again, there was not a long period of what we would call like homelessness. But obviously, some of the elements in that definition we talked about earlier, which was not being able to pay your rent, constantly moving around, moving in with family or friends for short periods of time. A lot of those elements were present in her life. And the children never were stable, maybe not so much homeless, but certainly they weren't stable. And so this is, what I was saying earlier about there's kind of like layers of instability, not always just being homeless. Next slide, please. So people with severe persistent mental health problems are at high risk of poverty and homelessness. And there is a direct correlation. Someone mentioned this earlier too. There is a direct correlation between the presence of a mental health diagnosis and decreased financial stability. And those things kind of reciprocate. Not having enough financial stability can certainly affect all the other areas of your life. So these two things just kind of rely on each other. The economic well-being is a factor in housing stability. These members of society often rely on social assistance, experience job instability, and they earn lower wages. And how housing instability can aggravate mental health symptoms, excuse me. So, if you look at the opposite of instability, it would be stability. So what are some of the elements or components of stability? Having strength, or strength in a situation, being dependable, having cohesion, being reliable, having firmness. So those are some of the elements or characteristics of a stable situation. And mental health tends to create instability, all of those other things that are the opposite of these. The state of continuing without change, like that's stability. So as you can see in the case of Miss Berry, there was constantly lots of changes, evictions and boyfriends and different houses and different apartments and different jobs. So that would be how her instability and mental health coincided. Next slide. Okay, so mental health deficits can lead to chronic patterns of negative behaviors in all areas of life that can decrease housing stability. And, so sometimes I remember when I was in grad school, I think there was a class that I took where we talked all about how the family is a system and, how we understand how one thing or one person affects the other person. So what mom is doing affects the kids, and what the kids are doing affects the dad, and what the dad is doing affects, everybody. And so that's how the family operates as a system. But even within our own individual lives, the different components of our personality, and it's kind of like we have our own little ecosystem. So, we have housing, and housing affects our spirituality. It can affect our physical health. It can affect our mental health. We have relationships with other people. How well we do at having relationships with other people, say like your landlord or your husband, if you need 2 incomes to, survive, or you and your boyfriend are living together and it takes 2 incomes to pay the rent and make sure there's groceries and such. Then if those relationships are failing, then your housing is at rent, and maybe your health is at rent, and your health is at risk, and your mental health is at risk, and your physical health is at risk. So all of the different aspects of your life kind of influence each other. I guess I need to slow down a little bit. Okay, so next slide. So what are some of the other things that I've seen within the population of women and children that I've worked with. And one of them is domestic violence. And 2/3 of homeless mothers have a history of domestic violence. 1/3 of them are actively fleeing abusive relationships when they become homeless. Mothers or couples raising children in a volatile environment or violent environment. Child Protective Services becomes involved for various reasons whenever there's domestic violence in the home. And then Child Protective Services also will have a goal to ensure the safety of the child. Ensure the safety of the child results in one or more adults in the home having to move out. And then there's a problem whenever the mother or whoever that caregiver is doesn't abide by the stipulations, which results in a loss of financial stability when the children are removed. So, when you talk about women and children, a lot of times there are certain benefits that come or attached to the children. So it could be, child support, or it could be Medicaid, or it could be food stamps, or I've seen cases where young girls had lots of children and they had no rent, and then they had like some type of voucher or assistance with paying their utilities. And so the cost of living for them was very, very low, but all of those financial benefits were attached to their children. So if something happened and the children were removed, it would result in them losing all of those benefits, which could result in homelessness. Next slide. Okay, another mental health condition that I have seen really affect housing stability is hoarding. And hoarding is the loss of unusable living space. So, that's clutter, and they just collect things and things on top of things. And so they have, it's kind of like the children don't have space to live in because, the living room is so cluttered up and the kitchen is so cluttered up and there's food in the refrigerator that is rotting, and the children are ashamed and their friends can't come over, and, family members can't come over, the neighbors can't come over. The children are dirty and their clothes smell. The children are often sick because of an unclean living environment. There could be filth in the home as a result of hoarding, or there is. Roaches, rodents, animals, lots of cats and dogs. I remember working with one family where in the children's bedroom, there was like, the cat had a litter of kittens. And so the kittens were like in the drawers. I guess the mom had put the cat in there to have the babies. But there was just kittens everywhere, places where the kids need to sleep and to put things up. And then legal issues can arise whenever there are fines, or if you're faced with eviction because of the hoarding, if the landlord becomes aware of the living condition. Once again, if Child Protective Services comes in, or oftentimes, people think like when there's a hoarder, we'll just clean the house, but that never works. Like they just, do it again. And so that can cause relationship issues, which can cause a husband and wife or a boyfriend and girlfriend to, break apart. And then of course, 2 incomes is better than 1. So there is a support that then leaves the relationship. One of the people leaves, and then that just leaves 1 income. Or in some cases, maybe the mom doesn't work, but the boyfriend or husband does, and they are the only income. So next slide. Okay, so here's another one. I've worked with lots of families that have had substance abuse issues. So what are some of the effects of this? Being unemployed, job loss due to chronic tardiness or absences, poor job performance, and accidents on the job. I mean, as we all know, if you have an accident on the job, sometimes the first thing they'll want to do is drug test you. And if you have a positive drug test, then you're going to lose your job. And, now there's a whole domino effect. What else goes along with substance abuse? Poor money management skills. So often addicts will spend their entire income in one weekend, not allocating their money properly. And I can remember one of the other housing hangouts that I was a participant in. They were talking about like the issues in construction. And so they were, they talked a lot about the cost of lumber and how COVID has driven the cost up, and, different factors in construction. But I remember one of the things the gentleman said was that oftentimes workers in construction will like get paid on Friday, and by Monday they're like broke again. And so, you know, they're not shopping. Typically they're using their money on drugs or alcohol. So this is another, you know, element of substance abuse that can contribute to housing instability. Next slide. Okay, and then this one is child mental health. You might say, well, you know, how does that really contribute to housing instability? Well, the first scenario I can think of is relates to property destruction and vandalism. So I remember working with a young man whose mother had some mental health problems. And so she was living on Social Security and she lived in public housing. And her son, as he, you know, got to be in his teenage years, he had some mental health problems and he was out of her control. And so he was roaming the neighborhood and he was tearing up things and throwing rocks and breaking windows and painting and drawing on things. And so then the landlord, you know, discovered like, whose kid is this? Who's doing this? And so, you know, they kind of presented her like, okay, there's some violations going on here. And if these violations continue, you're going to be evicted. And this woman had already moved like a couple times. I mean, she just kept having to move because of her son's behaviors that she could not control. But, you know, this was kind of like the last straw for her. So her, you know, solution to the problem was to kind of like, he ended up being in a group home. So basically her son had to go because she was going to lose her housing. It's kind of like the housing or the son, which one, you know? Also situations where there are child abuse. And again, removal of children that result in the decrease in monetary benefits. So I can't tell you how many situations I've seen where parents will like, a child needs a service or, you know, they need to move on to some other, you know, sometimes kids have to go to treatment facilities that are out of state. And sometimes there's situations where like, say like an aunt is willing to adopt a child or take the child in her custody, but she can't do that because the mom doesn't want to relinquish custody because she's going to lose all of her benefits. So, you know, it just kind of becomes this vicious cycle. But this, you know, these are some examples of how child mental health can affect the stability of the whole family. Next slide. So just in conclusion, poor mental health makes it difficult to conform to society's norms. And, you know, when you live in, whether it be a house or an apartment, there are certain norms. There's, you know, like ordinances in the city as to when you can make lots of noise and when you can't. And you can't have, you know, lots of cars and trash and things, you know, outside on your property. And you have to keep your home up. If you have a landlord, there's a certain expectation that you will keep the home clean and that you won't have, you know, lots and lots of people living in there. And so there's lots of societal norms and rules that we follow. A lot of them we don't even really realize it, that do contribute to our housing stability. And when you have mental health problems and you're just making lots of poor decisions, this contributes to, you know, the risk of you losing your housing. And just a statistic in there, in 2018, the rate of poverty for single mother families in the US was 24.9%. Just a couple of, and that's it.
Sorry. Thank you, Valerie, for such a great presentation. Dr. Sills, did you have any questions from the chat?
I think we're going to open things up. We received just a few questions in the chat, and we're going to call on Shawnee Black first to pose her questions.
Stephen, I may need your help because I posed so many questions.
I've got 3 captured here. Is there adequate supportive housing in Greensboro? What impact has there been from COVID on issues of housing and mental health? And then what can members of the community do who aren't mental health professionals to support mentally ill members of the community? So 3 really good questions there from Shawnee. Did you want to elaborate at all on those?
No, not at this juncture.
Okay. So is there adequate supportive housing? Anybody can tackle that one?
No.
Yeah, no.
No, there's not.
No, there is not. And I think, again, even defining what supportive housing means is sometimes problematic because, again, that could be everything from some pretty low level informal supports to a very sophisticated system with pretty elaborate support. So there really are not, to my knowledge anyway, I haven't seen really solid supportive housing options for folks who really need long-term stuff with support built in that is where they need it. Not that they have to go somewhere to get it or there has to be a crisis for it to occur, but that kind of naturally occurs, whether that's a living situation where there's folks where there are folks in residence who can deal with things at 2 a.m, or whether it's something more informal than that. So no, and I think it is a huge missing piece in our system of care in the Guilford County area in terms of housing. And it doesn't get probably doesn't get as much attention, I think, as it should, because we often, when we talk about homelessness, we often end up settling on this fairly small group of folks who need a lot of support. But when we look at solutions, we often don't really target that group.
I know that this has been an element in the 10-year affordable housing plan to address permanently supportive housing. Can anybody speak to those plans or where we are in that? Roxanne, I know you were working on this issue.
Yeah, there has been discussions. I think now they'll start picking up again. I think a lot of things have been more COVID related, but I know that the city and county have definitely talked about the need for permanent supportive housing and a couple projects with that. But I don't know those details. I just know that that's definitely in the plan. And just like Lindy said, there's just a big need for housing that has services on site. And I think more and more, as we look at other cities, like if you look at Charlotte, and I came from Asheville, where we had a permanent supportive housing project where we had things on site, services on site.
So Shani's second question was,
Wait,
yep.
Dr. Sills, I did want to just say, this is Mayor Nancy Vaughn, that we are actively looking at sites for permanent supportive housing. So it is something that is very top of our mind. Quite a few of our housing dollars this year went into the COVID shelters that lasted a few months. We did just get some money. We did get some COVID dollars in addition to the ARP money. So we're hopeful that before the bonds, that we might be able to find the spot for permanent supportive housing. And that will do that, bring all the wraparound services to the person, meet them where they are so they don't have to go to different places. But we are actively looking at some sites right now.
Excellent. Thank you for that update.
So Stephen, can I know you have 2 other questions that I posed, but can I ask a question now? Maybe we can wait later for the other questions, specifically about supportive housing. So what comes to mind, Lindy made a very good point when she said that supportive housing is very broadly defined, but I'm also thinking about, and because of COVID, my time frame may be off, but within the last year or so, there was a lot in the news about some agencies in the area that I think were providing some supportive housing services to people. And they were located at different apartment sites around the city. And there was, a lot of, there were some problems with those agencies. So one of the questions that I have is that model particularly problematic, or is there another model that maybe people on the telephone are familiar with that seems to be less problematic as far as financial malfeasance, let's say, for lack of better terminology?
Yeah, Sony, the situation that I think you're referring to really was malfeasance. It was not a legitimate permanent supportive housing option. So I don't think it's good to compare those situations to what a true permanent supportive housing option looks like and would accomplish.
Shoni, some of the ones that I'm familiar with in other areas range everywhere from, a project that I'm familiar with that was built and operated by a faith community that was a small set of apartments that had like 6 or 7 apartments. There was someone who lived on site. So again, if someone was anxious or having an issue in the middle of the night, there was somebody there. They didn't have to go out somewhere, or nobody had to be called on to come on site. There's one, I believe, in Roanoke where there are sort of SRO, single room apartments built around the common area where people can stay in, kind of like an assisted living. What we think of a lot of assisted living, where they can be pretty self-contained in their apartment, or if they need or want to interact with other people, or they need to contact someone who can provide some assistance to them, they're right there. So, they can take their meals in a communal dining area if they choose to, or they can do their meals in their own apartment. Again, something that we use very extensively for senior citizens. So kind of interesting that we haven't used it as much for other people. But I think there are a variety of models. And again, I think there need to be a variety, because not one model works for all people that are in need of services. There are some places, on the West Coast that have developed tiny house communities where tiny houses are built in a community that offers some supportive services as part of that community. There was a really cool community, I think in Oregon, that was built as a multi-generational and interability community, where it was a mixture. It was a community with different types of housing, but there were central buildings and central activity areas, and there was a mix of older folks and younger folks and folks that needed assistance. And again, they kind of lived interdependently. And that model worked for a lot of people. It wasn't a professional model. It ended up being a very just a community collegial kind of a model. So I think there are lots of best practices out there, and there's also lots of very creative options.
And I put in the chat for everyone, the Corporation for Supportive Housing, CSH.org. They have a lot of examples, and those are also plans that were supported by MCOs, managed care organizations. So there's large and small ones. And if you want a website to look at more different models of care.
Thank you. Derek has his hand up. Derek Joyner.
Hi, can everyone hear me? Hi.
Yes.
Okay, well, I've come to these housing hangouts quite a few times. I try to free up my schedule to do them, but I just want to, there were a couple of people actually, I want to tie in a few of the points for my personal experience for life. And I would like to pose after I tell my little story or whatever, I would like to pose a general question to the group. For example, I'll tell you a little bit about me and how I've experienced it. Now, my parents, some of the situation you were talking about is very similar to what my family went through. My mother and father, my mother left school and started a family with my father. They got divorced. She had no job skills. So, and dad didn't pay child support for whatever reason. So we went into public housing. And this was, and I've lived this. So a lot of this that they've been talking about, I've actually lived it. Now, my mom, I'm fortunate my mom, well, I don't think she had any mental issues, but my mom was, very loving and very caring. So I got a very nurturing home. But the one thing that I did notice, I used to live in Thomasville, was that you had families or girls or whatever you want to say that would have children and continue to have children to keep the benefits going. You know, like they would keep having babies so that they would keep getting the check every month. And then, you know, you wind up, you got 5 or 6 kids. And so at a certain, but then you had people coming into your life to almost harass you. Like I don't know if it were social workers or whatever. They would come into your house and basically just look through your cupboards, look through your dressers. They wanted to make sure you had nothing nice at all. It was like their job was to keep you down and subservient so that you could keep depending on them. If they actually found you with something nice in your house, they could actually decrease your benefits because they didn't want, you know, it was like, well, you shouldn't have this. It's like the whole complaint lately about somebody living in public housing and having an iPhone, and people are outraged. Okay, so you have a whole set of, like, I know that they were saying going to mental health, you should go in and make a visit and not an inspection. And that should also go in place for people that don't, quote unquote, have a history of mental health, because I helped a homeless family. Dad had 6 kids. And I think some of you, I may have said this probably around December. I think I lost my connection. Okay. Had 6 kids, and the mom was crack addict. Dad was trying, but as a Black male, I tried to support him, and I found it was very, I don't want to say it's interesting, but I found that he had a lack of drive because it was easier for him to rely on social service than for him to tough it and try to do something to get on his feet more, to get out of that situation, because he was living in a homeless shelter, and then he went to the one over in Wendover, and I noticed that he got the way that the people treated them was very almost inhumane, because it's like, you're in this situation, so we're just going to kick you. You know, the way that this family was treated half the time, like, you can't have visitors, you can't have this. And I was like, we need to learn how to treat people better. And we also need to figure out a way that when you see people in a situation where they have generational social service dependence, how can we help them feel better about themselves to get out of that? My mother had to make the decision. I'm telling you, this is as a family, and this almost brings me to tears when I think about it. I was like about 10, 11 years old, and my mom had just had enough of these social workers coming into our house. She sat us down in the living room one time, and she said, and it was 4 of us, and she said, I have a talk with you. She said, listen, we need to make a decision. I'm tired of these people treating us like this. I'm tired of this. We need to get off of this because we are better than this. My mother was actually saying this to me as a 10-year-old child. And she said, I want a show of hands. Everybody got to vote. We want to get out of here. And she told me, we're going to suffer. We're going to go hungry sometimes until we figure it out. But we have to get out of this because I don't like the way that this is making us feel less than, you know, and so my question is, I haven't had to deal with this in a long time since this guy that I was helping, but it seems like it hasn't changed. Like the attitude towards people that have fallen on, you know, for whatever reason, that could have been any of us. Okay. But that doesn't preclude you from being treated as a human being and being treated humane, because when you're treated less than, ultimately it stacks on your psyche and it makes you feel less than, so you do less. So we have to do better. And does anybody have any suggestion or comments or anything? Because it really bothered me. And this was literally less than 2 months ago when I was helping this guy. And so this is very recent. And there's got to be a better way to help people and not make them reliant on us. And we're liberals. I'm liberal, and I'm assuming a lot of us are. I don't know. But we have to do better to don't make people reliant on it and make them feel like, okay, I'm going to depend on this for a little while. Then I got to get out of this. So we have to do a better job than that. What can we do? So I'm gonna shut up.
So I'm just gonna kind of throw this in there. I certainly can't speak to your mother's situation, but again, you know, I've been working with doing in-home work for practically 20 years. And I was doing intensive in-home for a while, which started off as family preservation. So that's where all the therapy takes place in the home with the family. You're like out in the community. And then I was in Florida because I grew up in Florida. I was in Florida for about 6 years during my adult life. And I was a guardian ad litem volunteer for a little while. And I worked in child protective services for about 1.5 years. So kind of had an opportunity to do a few different things while I was in Florida before I came back. But what I saw, what my experience was, sometimes, you know, you talk about, let's say like public housing or people, you know, receiving certain benefits. I feel like there is a percentage of people who don't really have mental health problems. They've just had some, you know, I don't want to say bad luck, but just, you know, things didn't fall the way that they needed to fall in order for them to be on their feet. You know what I mean? But then you've got a certain percentage of people, and that's kind of what I was talking about earlier, that do have mental health problems. And so they may not necessarily be homeless, but their mental health deficits create barriers for them to put all the pieces of the puzzle together in order for them to become, you know, more self-sufficient or more independent. So, you know, you just got to be empathetic to that. There's a lot of people out there that just can't seem to put it all together. And, you know, and as I was saying earlier, it's like, you know, their decision-making skills, and they just constantly make, you know, bad decisions, and, you know, they can't keep a job, or, you know, if you try to suggest things to better themselves, like let's try to go to school, or, you know, go back and get your GED or your high school diploma, and, you know, education can really boost your income, or you try to get them therapy to learn how to get along with other people, how to accept authority, like on a job. Then if they can't master those skills, then it just becomes a cycle for them where they can't seem to get out. And as in this new position that I have as system of care coordinator, I've been on this job at Sandhills since November of last year. I have made an effort, me personally, to try to get to make sure that we are customizing services for people, that we're customizing treatment for people. And I think what happens is the system kind of just gets overloaded. You know, I mean, CPS workers have a lot of kids. When I was in Florida, I think the max caseload that we were supposed to have was 25, and I had like 37 kids on my caseload. I was literally working from 6 in the morning until 11 o'clock at night. I mean, constantly, day after day after day. So, you know, we get a system to where the burden of work is so heavy that people get into this thing of where we just do cookie cutter stuff. We're running on autopilot because it takes, you know, it takes a little bit extra to individualize services and treatment for people. And that becomes difficult. It's a challenge. So I don't know if that exactly, you know, answered your question, but just to kind of speak to what you were saying.
It did.
On both
yeah, go ahead. I'm sorry.
Yeah, to kind of follow up on what both of you all have said, I think, you know, one of the links we're kind of missing in the system is something that looks at those folks who can't comply for whatever reason. Whether, you know, I was taught that you know, in context, all behavior makes sense. You have to kind of, people don't typically act just completely irrationally, but they're responding to something in their environment. So, right, if I'm in a shelter and I feel like I got to leave because I think the cook is poisoning me, then my urgency to leave makes a lot of sense. It's not abnormal behavior. It's normal behavior in the context of where my head's at. So I think, you know, sometimes we try to fix people more than we try to fix systems. And I think, you know, some things can't be fixed, or they're not going to be fixed quick enough to get people housed or to take care of the next generation that's coming up while we're trying to fix mom. You know, the kids are getting older, and they're going through these experiences. So I think one of the things that we really need to look at is, what about the folks that we just can't fix? What is the answer? There has to be, we have to look at a way that people don't only have an option of meeting all of our expectations or being on the street. There has to be some middle ground where folks can do what they need to do and still be housed. And so I think that when we, and it always interests me when we talk about poverty and the way people spend money and that people make foolish decisions. I grew up near the coal fields of West Virginia, and the big joke always was that there would be big Cadillacs parked in front of tar paper shacks, and how irresponsible to buy this big car when you didn't have indoor plumbing. But again, in context, things make a lot more sense. So what looks like a foolish financial decision to most people may make perfectly good sense to the person making that decision. And I don't know about you, but I know a whole lot of people with a whole lot of money to make some really foolish financial decisions. So foolish financial decisions are not limited to people without means. It's just that when people without means make them, they tend to come to our attention more, and we tend to be a little more judgmental about them than when somebody buys a yacht. I personally don't think anybody needs a yacht. But, when people make that decision, we don't say, wow, they're really poor decision makers. So I think, again, kind of putting things into context and looking at, we all know that the justice system has become the #1 provider of mental health services. Why does somebody have to break the law to get the assistance that they need? Why can't we look at that maybe you are going to make poor decisions, but how do we still look at housing you and keeping you in as comfortable a situation as you can tolerate and as we can provide, while we wait on you to get better at all those things that some people may never really get better at. And again, getting better at tends to be a very judgmental call. Whether a decision is a good decision or not tends to be very much influenced by people's personal beliefs and personal values on whether we think it was a good decision. So I think, again, for me, part of this is really about building something and putting in place those things that can help you meet your needs while we're waiting on you to get better, if you get better at things. And it's interesting, Derek, I know the gentleman that you're speaking about, I've worked with him. So this is a small community. But I think, again, what do we have?
Okay.
What do we have for that man and those children while we're waiting on him to build that drive? I mean,
He's gone now. He left.
He'll be back.
I know, I can tell he has a cycle, but what are we doing? What are we doing to help him break that cycle? I try my best as another Black male. I grew up poor. So I have a house now, I have a really nice little sports car. I mean, I did, I'm doing well, I'm middle class. And from what I understand, what about 5% of people make it out of the economic class that they were born into, about 5% or less or something like that. So I'm fortunate in that respect, but I had a very caring mother and I had a lot of teachers. I was a bookworm that were like amazed that this little Black kid was smart, and they sort of, but what are we doing for people like him that are in that cycle? And, do we have something? I mean, I tried my best and I felt like I tried to get through to him. And, it's like, you can't just throw money at a problem. It just creates him. He didn't want to work. I don't know if you know him, and I hope I'm not saying stuff, but he gets more money just by doing nothing. You know what I mean? And so that he doesn't want to do anything because he doesn't have to, because he's got money, he's got food stamps, he's got the stuff coming in, but I could talk from talking to him, he's just mentally beat down. So I'm looking at the kids, and he's gonna pass that to those kids. And that's destroying me mentally, because I'm looking at the kids, I'm like, are we going to see you doing the same thing that they did, which maybe his parents did over and over? Where do we break the cycle? How do we break it?
Some really important points being made. And I want to point out that in the chat, we've had several other side discussions going on. Harrison Spencer, for example, talks about how social workers have a hand in the mistreatment and in the history of service provision have sometimes made things worse. Shawnee points out that there's systemic issues, racism, the structure that creates barriers for people and judges people just based on what group they belong to. So elements that we have to keep in mind as we discuss the personal issues versus the structural issues in providing services and its relationship to mental health. I think Destiny Alston has a question to ask now.
I do. I kind of want to make a segue into talking more about the housing first model and kind of like what are the approaches to providing housing to those with mental health issues, how they can kind of just lead to more sustainable ways to improve their well-being. This is a question for everybody, not just the panelists.
Can somebody help define the housing first model? And I think Nakia brought it up in some of the work that PATH does in connecting people to housing. We know that this is the model that the COC or the Continuum of Care is using, and HUD. Tell us a little bit about what housing first is and how it relates then to supportive services.
Yeah.
Go ahead. You can.
Okay. So the housing first model is basically a model, and there's different variances to that. Personally, I feel like we should be using a different model because some people are just not ready for housing. Like there are people who have a lot of barriers that prevent them from being successfully housed. And so the housing first model basically sets a precedence of housing people first and then focus on other needs. And then once they're housed, then they can work on substance use and mental health and primary care and those things that once they're housed, they're more able to accomplish those other goals, and which are absolutely great and fundamental in helping someone to, be successful in life and thrive and reach their goals. However, some of the issues that come with that is we have to be mindful that to be chronically homeless means you have not slept in a place that is suitable for human habitation for at least a minimum of 12 months. So for instance, we have clients who have been chronically homeless for 5 years, 10 years, 20 years. And so to say, hey, let's get you in a house can be detrimental. That can exacerbate their mental health because it's quiet. So they're not used to not hearing trains or not hearing sirens or other people talking. There's seclusion because no one else can live with them or come in with them. So we have to prepare people for that transition. You just can't throw someone in because we feel like that's what's best for them to be housed first. I think that it should be based on the person, like they should have skills that leads them into that transition. And so for us, what PATH does, we have that capacity to prepare them because we meet them where they are outside and we talk about what that next step is going to look like. First of all, we have to build rapport to let them know, hey, you are going to be in this unit alone. Your friends here, your boyfriend here, your 6 cats, 5 dogs, they can't come with you. And it's all about, for me, having a very realistic and honest conversation with people. I think that goes a long way, because to paint a picture of, oh, you're going to be housed and everything is going to be fixed in your life now is a lie. And so we as a people in a group need to be honest with people and just say, listen, it's going to be hard. And I understand you feel like in this moment, if I can get housed, then I can get a job. Well, do you have a resume? Do you have you worked before? Do you have, what's your employment history like? So there are other things that we can't put the cart before the horse, like Lindy said. So, just helping them to understand there's more to just being housed, and that's the fix all be all. And just honestly painting a picture and allowing them to ask questions and, just understand that it's okay to just take a moment. I mean, honestly, you've been out here for 7 years, 2 more weeks to get you connected to vocational rehab because you want to work, to go through that process of filling out an application, getting you registered with their system so they can help you with a job coach who is then going to come out and meet with you and teach you how to present yourself in a professional manner at an interview. Try to get you some clothes that are appropriate, that aren't dirty, that don't allow you to look disheveled, so that you're going into an opportunity well prepared versus, well, once I'm housed, then I'm good, because you're not.
I think for me, the definition of housing first really has to do with not being able to require that people have certain things in place or do certain things in order to get housed. So not, that it's not a contingency of this program that you have to be in substance abuse treatment in order to get housed, or you have to go into mental health treatment, or you're not eligible to be housed. It I think was put in place originally to, people had to jump through a whole lot of hoops in order to get to housing. And some people were never able to get through those hoops, so they just never got housed. And once housed, it also means that the housing can't be made contingent upon. So, we got you housed, but we can't force you to go into substance abuse treatment as a contingency of staying in that housing. For me, this is a really tough issue, because I think the getting ready part is really hard for me. Again, my background was originally developmental disabilities, and I watched people try to get ready for things their whole lives, and they never got ready. Support employment, the idea was that you'd get ready to go to work. Well, what I found was putting people on a real job worked much better than trying to get them ready to go to work. We just did it. So I think it's, and again, for me, when we're looking at continuum of care and we're looking at the whole system, is where is the place in the system for those folks who aren't, quotes, ready? Where's the place that there's an option between living in a tent and living in your own apartment in some apartment complex? What is the option of where maybe the 4 dogs and the 3 cats and the mother-in-law and whoever can come with you? That you're not totally alone, because we see that very frequently with folks with mental health issues. We would have people in our shelter, they'd leave our shelter, they'd go into an apartment, we'd think this is great, and they'd come completely unglued. After a week, they're like, I'm bored, I'm lonesome, there's nobody here in the middle of the night to talk to. Well, maybe we need to look at options for folks that provide some of that stuff. Maybe there's not just an option of getting you in your own place by yourself. Maybe there are some mutual group living situations. College kids do that all the time. 4 or 5 college kids live together. So, maybe this goal, again, I think we tend to frame this by our own image of what it means to be housed and our own ideas of what we might like. But maybe there's options that are different than what we normally think of. Maybe there's places, maybe we need some options where people could go in and out. So that if I can be housed right now and I'm comfortable right now, I can be here. But if I all of a sudden think that y'all are poisoning me, I can leave. And that doesn't mean I failed or flunked out, and then I could come back at some point if I needed to come back. So again, I think the flexibility of a variety of options for folks truly where they're at, and understanding that where they're at changes, is something that we're kind of missing. We still don't, I think, have a true continuum where we can meet the needs of most people. You know, having again, joint housing where 3 or 4 people could live together, their choice would be helpful. And again, I don't, successive approximation to me is problematic, because the best way to learn to live in a house is to live in a house. It's hard to learn to live in something that you're not in. So I think, but again, that doesn't mean to me that we just put people in houses and say, have at it. You know, again, part of that is listening to what do you need and what do you want, and how would that look for you if we could develop the perfect situation for you. What would that look like? What do you need? You know, the dog thing is interesting. You probably just heard my dog bark, but you know, that is a barrier to a lot of people that have mental health issues and are experiencing homelessness, is the number of places where they can't live with their dog. Well, if that dog is what you have and that's your companion, that's a deal breaker. And it's really easy to say, well, see, we offered him housing, but you know, he wouldn't take it because we wouldn't take the dog. Well, you know what? I wouldn't take your housing if I couldn't take my dog either. And I don't have a diagnosis. So, you know, I mean, I think sometimes our standards are just way too high. And in some ways, the best way to solve a problem, again, is to change the standard. You know, one of my favorite examples is I worked with a young man who went off every time somebody started a dishwasher. I don't know what his trauma background was or why he did that, but every time somebody started a dishwasher, he would lose it. I mean, he would flip his stuff. You know what I did? We stopped starting the dishwasher when he was around. We started starting the dishwasher in the middle of the night when it would have bothered him. Problem solved. And much easier than fixing him. We just changed the environment. So I think, you know, I always tell people, I can't control people. What I can control is environments. And I think we've missed the boat on really looking at controlling environments being the emphasis rather than the emphasis on trying to control people.
I think Mayor Vaughn had something that she wanted to add. Are you still there? We lost your audio there. Oops.
Sorry. I do want to add, though, I see the permanent supportive housing is housing first on steroids, you know, where you really make sure that people have the services that they need where they live. And a lot of the models that I've seen with permanent supportive housing, they have a 90% success rate, which is because they do that long-term transitional housing. You know, we're talking 18 months to 2 years, and we know that people are going to fall out, but they can come back in and get the services they need.
Thank you. Brooksanne, did you have something there as well?
Yeah, I just wanted people to understand the historical perspective with Housing First, what came out of New York, and I think it was $1 Million Murray, what's his name? There was a story about, and they followed him, and it was $1 million bill in the hospital and institutions, and then they put him into an apartment, and it was only like 10% of the $1 million to keep him in housing. And so that's the model that started it all. And we also need to remember all the success stories out of it, even though a lot of times we pick out these negative things where it doesn't work, but you know, there's millions of people that it has been successful. And I think all of us that are in the service world and been on the front lines, a lot of times we get disheartened because we see how sometimes it doesn't work, but just remember it has worked for many, because before Housing First, I'll tell you, being a social worker in shelters, I mean, it was years that people had to go through hoops to get housing, had to do treatment and all these, you know, and a lot of times they would die before they got housing. And Housing First has flipped that dynamic on its head, because it says, hey, let's put them in housing and then give them services. So I just want us to make sure that we look at the bigger picture and not just from our own experiences, but how many people it has helped as well.
Were there other questions that the audience has for the panel or the panelists have for each other? This has been a rich discussion that's varied from poor quality housing and housing instability causing mental health resulting in difficulty in finding and getting stable housing, a kind of causal order in both directions there, and a very complex issue to address. Both mental health and housing are systems of service provision that don't always work well together. Other questions that folks might have?
Just for clarity, I didn't know that there were different models to the Housing First models. Like I was told there was somebody who came here from Canada and talked about like the Aura Code and implementing that. But then CSH also has a different type of Housing First model that they use. The particular one that I was referring to didn't really establish a community support system for people going into housing. And I feel like that is really important to someone, like Lindy said. We see a lot of people who have pets, who have significant others who are not married. And it's difficult to do for one and not do for the other if they're together, or just say you can't bring your pet, but you can come and you'll be out of the cold or you'll be out of the elements because you will have a place to stay. But because my companion can't come, the person who helps stabilize my anxiety and someone who gives me relief can no longer be with me, then I am going to turn that down. So as far as the CSH model, from what I understand, and if I'm wrong, please correct me, they actually allow for establishment of support first in that housing model. So establishing a therapist or a counselor, trying to figure out, hey, you have animals, you have pets. Okay, let's see what we can do to try and get a doctor who can certify that, hey, this is a support animal so that they can come in and live with you. Maybe we can put the animal through some training in order to get them certified so that people aren't alone during this transition in that walk. I just don't think that's fair. You don't get a fair chance when you just don't have the necessities that you need for support, because it does take a community. And this is something that's new, that's different, that if you've not paid a water bill in 10 years, you haven't paid a power bill, hey, we can cover that for you. You have permanent supportive housing, but you get a check, you get money to pay this power bill. Well, do you have an account? Do you know how to get a debit card? Do you know how to use the ATM? Do you understand that if you only pay a portion of that because that's what your friends told you to do, if it's $100, you only pay 40 every time, you're still going to owe more money in the long run because you're never going to get caught up. And then if you don't have the wraparound services to maintain cleanliness of your unit, or because your mental health is so severe that you end up losing your place, well, then now guess what? You have an outstanding balance with Duke Power because you didn't pay your bill. So you just don't have the tools to adequately provide you with the support that you need. And I think that particular model helps with that. And it also assists with a warm handoff to different community partners who can assist and pick up the slack. You pass the baton. Not one agency can do it all. So everyone is a piece to the puzzle. And like Lindy said, there is no, I mean, it's really complicated and it's very complex. So there is no right or wrong answer or a solution to the problem right now. But I think there has to be some type of innovative ideas that we implement because, you know, everybody's not fitting in the model. And that's unfortunate. And because of COVID, we have more people that are coming from out of town into Guilford County. And, you know, we have our own population here that we're trying to serve. And so we're constantly getting additions into that. And, you know, it's complicated, you know?
It is a very complex issue trying to address all of the elements of the continuum of care in a way that's just and honors individual differences, as well as addressing the structural impediments that people experience. As we wrap up here, I'm going to put out an appeal. The city has an emergency rental assistance program that has been funded through the federal government directly to the city and the county separately. The Center for Housing and Community Studies is currently assisting people in applying for this program to pay back rent that has been impacted by layoffs during COVID, hours being reduced during COVID, children being at home and parents having to stay at home, all of the ways in which folks have been impacted. This emergency rental assistance program is smooth and quick, but it requires that folks are putting in information into the neighborly system or applying through the Salvation Army on paper. We are participating through our Cottage Gardens Resource Center with assisting folks in completing their applications, getting their paperwork together. And so we're looking for volunteers to assist in this process. I'm going to drop in the chat right now. We're there on Tuesdays and Thursdays and looking for volunteers who might be able to assist with contacting residents at the complex, walking them through the process, assisting in getting paperwork together. We have 3 staff that are working on this currently, but we've seen that there's a greater need than our capacity to get people registered into the system. So again, if you're interested or know somebody who has some time availability to volunteer with applications, please contact Atija Farmer at ajfarmer@uncg.edu. It's there in the chat to arrange for training to be a volunteer on this project. We're hoping to assist other communities as well as they apply for this program with the city. Any parting thoughts, Destiny? Thank you for hosting.
Thank you. And no, I just want to thank the panelists for just adding to such a great discussion and just thanking the audience for, you know, wanting to really flesh out these points. So thank you everybody for coming.
I agree. Thank you so much to our panelists. And we'll see everybody next month to talk about reproductive justice and housing issues. Be sure to sign up for that event on the first Friday in June. Thank you, everybody.
Thanks, everyone.